Welcome once again to today's session of Pediatric Teaching Files. We are here physically at the IIP Mumbai office. Some students have also joined us and the rest of you are online. Once again, a request to all of you, if you start coming physically, the learning will be better, as is evidenced by last time's experience of those who came here physically. Now, today's session is by Dr. Aditi, Shah, and myself. So the first part will be examination of cranial nerves. Aditi will be giving you some basic concepts, and then we will also be demonstrating the examination of cranial nerves on some volunteer patients, and that will be followed by a case presentation by Dr. Saurodip. So let's start. Aditi, you can start.
Hello everyone, also those who are online. Please note that you may not be able to see me throughout the session because I'll be standing close to this laptop to change the screens so that everyone over here as well as everyone online can see the screen. So today our topic is examination of cranial nerves.
Those who are online, can one of you unmute and tell us whether you can hear us clearly and whether you can see both the windows?
Can you hear this?
Yes, sir, it's fine.
Yes, sir, we can hear you.
Okay. So from this time, we are going to start with these sessions which are asked as observed OSCEs. The question is put in front of you. The examiner will be sitting in front of you. You are not supposed to ask any question to the examiner. You all know that already, right? The examiner is not going to ask you or tell you anything in between. Just reading the question, there will be a child sitting there and you have to perform the examination. There might be some questions where the examiner will stop you in between to tell you something, which is a part of the questions which he has. He's going to ask those questions to everyone. Then he has a list of answers with him. Whatever you all are answering, he'll go on picking depending on how many marks you get. If you answer most, then you get more marks, right? So this is one of the common questions which is kept in observed OSCEs, but I'm not going to just focus on just the question and answers. We are also going to talk a few things about few concepts of cranial nerves because I think it is important that you revise these. You all know these already. It's just revision of what you already know. So of course, I mean, the first question you all already know what it's going to be. Can one of you name all the cranial nerves?
First one is olfactory, second is optic, third is oculomotor, fourth is trochlear, fifth is trigeminal, sixth is abducent, seventh is facial, eighth is vestibulocochlear, ninth is spinal ninth is glossopharyngeal, 10th is vagus, 11th is spinal accessory, and 12th is hypoglossal.
Perfect. So this is most important, right? We should know the names of all the cranial nerves. You all know it already. And I also want to encourage all the students who are attending online. If you all want, you all can unmute yourself and answer even in chorus, no problem. Even when the students over here are answering, no problem. Please keep answering. That's most important. So now you know that these cranial nerve nuclei are present in the brain, right? We need to know this because later it will be important because this is going to help us localize the lesion. Now we are interested only in three parts here: the midbrain. Can you see the midbrain? The pons and the medulla. Right? I'm not able to move the mouse exactly how it should be, but you all can see the markings. So can someone tell me what are the cranial nerve nuclei present in the midbrain? Anyone? Midbrain? Yes.
Third and fourth.
Absolutely perfect. Thank you very much for answering. Third and fourth. I cannot see the. Maybe I'll just. Oh, you all can see? Third and fourth. Can somebody tell me what are the cranial nerve nuclei in the pons? Perfect. So 5 also, right? 5, 6, 7, 8. 4 nerves from the the cranial nerve nuclei from the pons, and of course the remaining from the medulla. Please remember these 3, 4, 5, 6, 7, 8 from pons, 9, 10, 11, 12 from the medulla.
Ma'am, kindly upload the slide so you can't see the slides.
All those who are unmute, and please make sure you all are mute so that only when you want to answer you can unmute yourself. The second slide is again what is their action. So you should know this, because when suddenly you see a exam question saying examine the seventh nerve, you should know, is it motor, is it sensory, is it both, right? So can you tell me which of the nerves are sensory?
Olfactory,
Yes, the first, second for vision,
optic,
and
third,
the
facial, eighth
correct?
nerve.
So first, second, and eighth are only sensory nerves. Which are the motor nerves? Only motor. Eye movements, which nerves?
3, 4, 6.
Perfect. 3, 4, 6. And remember 2, 11th and 12th, right? Perfect. Very nice. And of course, the remaining nerves 5, 7, 9, and 10 are both motor and sensory. What does this mean? When you are examining the seventh nerve, don't forget the sensory component. This happens. I mean, of course, we have been, whenever we have students, I think it's very common during the exam. Just check the motor component and forget the sensory. Don't do that. So now I want you to, this is just a concept. What do they supply? Not talking about the muscles. I'm talking about, suppose we are talking of the right-sided cranial nerves. They supply the right side. For example, if I say that I have a right eye ptosis, it is my right oculomotor nerve, my right-sided nucleus of oculomotor nerve. There is no crossing happening here. Correct? Right side, right structures are supplied. It's important to remember that all cranial nerves are supplied, the nuclei are supplied by the cortical fibers from both sides. The right is supplied from left as well as, but there is an exception to this rule, which you all know, which is the seventh nerve nucleus. And this anatomical phenomenon is going to help you localize the lesion the best. So I'll just tell you in short, what is the seventh nerve nucleus? Why is it hybrid? So seventh nerve nucleus has two parts, upper and lower. The upper part of the facial nerve nucleus is like any other cranial nerve nucleus. It is supplied from both sides. Lower half is supplied only by from the contralateral side. Correct? The lower half receives from the contralateral side. 11th and 12th nerves receive only from the contralateral side. These are like any other spinal nerve nucleus. Okay. Now let's come to the first question. Najia and Alfia are here. They are very cute kids who have volunteered to help with examination. So, ek jan aa jaiye. Come. So, when you are thinking of the second nerve, what should you think of first? What is the name of the nerve? Optic nerve. So, you are going to see what? What? Sensory? Vision. 3 components of vision are checked. Perfect. Perfect. Color? Absolutely. So when you're talking of acuity of vision, what is it? How well the child can see, correct? So what are the things that you will use? Now this we don't need her, but just in general, how will you check the
Bright object, a torch or a color for object. If a bigger child, we can use numbers or we can use Snellen charts.
Yes. So Snellen's chart is for which vision?
6 by
Long distance
6
vision, right?
meters. 6 by
And for
6.
near distance, you can just ask the child to read. If the child can't read, like you said, there are these charts with dots available, which the child can count. Even for Snellen's chart, there is an option. There is an E. So which side is the E facing? You all must have seen those charts, right? Now, I just want to ask you here, how much distance should the Snellen's chart be from the patient?
6 meters.
6 meters
20 feet.
or 20 feet. Everybody online also, please answer. I want to hear chorus answers. So if your clinic doesn't have a distance of 6 meters, you can ask the child to sit at a distance of 3 meters and put a mirror in the front. Ask the child to read in the mirror, right? When I say vision is 6 by 6 or vision is 6 by 60, which is the better vision?
6 by 6.
6 by 6 is the better
6 by
vision. What
6.
does it mean? The second last line in the Snellen's chart. A normal average child or a person is able to read from a distance of 6 meters. That means that child's vision is normal. 6 by 6. 6 by 60 is when he cannot read even the first or only the first line, which is labeled as 60, just about okay. Correct? Yes.
So in other words, the numerator 6 is the distance at which the patient is able to read that properly, and the denominator is the distance at which a normal person is able to read it properly. So if it is 6 by 60, that means a normal person can read it from 60 meters, but the patient can read it from 6 meters only.
Right? So this is how you know what the vision is. Don't get confused between the numbers. Sometimes it's by 20 because it's up at a distance of 20 feet.
What you said about if we don't have a distance of 6 meter in the
Patient, you put a mirror.
Yeah.
The Snellen's chart is kept at a distance of 3 meters. The child is sitting with his back facing the Snellen's chart and seeing the Snellen's chart in the mirror. So this becomes 6 meters, right? Next. So for field of vision, I want somebody, one of y'all, to come and demonstrate how will you check field of vision for our dear Najia. And think of this as an exam question, okay? In the exam, if this question is asked, the patient is going to be an older patient. So don't worry about child not cooperating. Okay, Saurabh, you want to try?
Ma'am, slide is not moving. Can you please make it screen share?
What is she?
What did you say?
Slide is not moving, ma'am.
Slide is not visible.
Not visible, ma'am. Only in the it is showing first slide. It is showing only the first slide, examination of cranial nerve and your name.
I don't know one.
Yes, ma'am.
Okay, अभी एक बार तो रहने दे. Aditi, let it be just now. Then when you share again that time. You just means you give your instructions in the mic because everyone has to hear.
Can you stand a little? Yes, what will you do? I'll hold the mic for you.
So आप एक आंख ऐसे बंद करोगे, okay? And
so remember, Saurabh, whenever you want to, you start with all the basics, right? Hello, I am Dr. Saurabh. I am going to check your vision. Are you okay in Hindi or in English? Say these things. And then start. So then whatever you're doing, you say, I will stand at a distance of 1 meter from this child.
Okay.
While you're saying, even if you're not telling it to her, you have to say these things. Right? Next.
बेटा आपको जब भी ये फिंगर्स दिखे तो आप मुझे बताना, okay?
Before that, you want to do something?
Statement you will tell them as an explanation. No, you have to be more explanatory. No? They are not medical students. So
Okay.
you told her to cover one eye. How will you cover the eye?
ऐसे
So she was putting her finger.
ऐसे कवर करना है.
Now you have to
Like this.
first give a demonstration. So first just
Show her what she is supposed to
Okay.
see.
जैसे आप मेरे तरफ देखो, ठीक है? जैसे मुझे अभी ये दिख रहा है तो मैं हाँ बोल रहा हूँ, तो आपको भी ऐसे करना है, ओके? ये जब दिखेगा
जब
तभी
भी
हाँ
उंगली पास में आएगी, मैं दूर से उंगली लेके आने वाला हूँ. अगर आपको उंगली दिखे, आप तुरंत मुझे बोलना. But before that also, you have to be at the same level from the patient, huh? And you have to cover the same side which the patient is covering. So if the child is covering the right eye, you have to cover your left eye. You're not doing that. You're doing the right opposite eye, right? Yeah. Then after you tell her what she's supposed to see, then you start moving the finger.
Okay.
आप सिर्फ मुझे देखते रहना.
हाँ, अब मेरे तरफ ही देखो. अभी दिख रहा है? दिख रहा है? अभी?
Swing your hand from as far as you can get.
Okay. दिख रहा है?
You can
नहीं, मेरे
also
तरफ.
use a colorful object.
हाँ, आप मेरे तरफ ही देखते रहो, ओके? अभी? नहीं दिख रहा है. अभी? ओके, ठीक है, थैंक यू. ऊपर, अभी ऊपर से हाथ में नीचे लाऊंगा, ओके? और आपको बताना है. अभी? दिख रहा है? ओके.
So basically,
Are we making some error? Anybody?
both sides we do matlab, no.
You don't do both sides together, but what is the other error? Should you be doing this?
It should not be producing any sound.
This is a sound. Why? We are not doing any sound here. Okay. So it should be, and it shouldn't be two fingers. So from, if it's better to have one finger and then you move it so that they can see the moving finger. So make the object very distinct and clear. Okay. That's the way you have to do it.
I'll just show you one more thing, Saurabhi, that when you, yes. So when you are at the level of the patient, then only your both fields of vision are going to match, right? So explain to the examiner that I would like to sit at the same position and when you cover this eye, swing this eye from far. You should also not be able to see it. Move it. जब भी आपको दिखे मेरी उंगली, आपको मुझे बताना है, ठीक है? अभी मैं दूर से ला रही हूँ, उंगली को नहीं देखना, देखना मुझे. I mean, assume that I'm covering my same eye. And अभी आप मुझे क्या बोलना, आपको कभी मेरी उंगली दिखे, हाँ दिखी, फिर से करेंगे, ठीक है? दूर से लेके आ रही हूँ, आपको उंगली दिखे तो आपको मुझे अब भी दिखी, है ना? सेम ऊपर से करेंगे. So swing your hand from as far as you can. दिख रही है आपको उंगली? Very good, excellent. And this will be done in all positions and then in the other eye as well. Swing your hand from far. You should not be able to see the hand first, the finger anyway, because then she will say she can see it. This will tell you field of vision, correct? It will help you find if there is any spot of blindness or any scotomas.
छोड़ दो बेटा.
हो गया बेटा.
Very good. Thank you. रुको हाँ.
So the third is color vision. Which chart? Yes, red, green, and blue. Now, पुढे नहीं जाते screen. So the next is pupils. Okay, now whenever you're checking the pupils, you're checking the second and the third nerve together. Just telling you, for vision, the second nerve is the afferent optic nerve. It's carrying the sensation to the brain. Oculomotor is the efferent. It is going to, it innervates which muscle in the eye? The sphincter pupillae muscle. What does it do? It constricts the pupil. So when it receives information, it will constrict the pupil when the light is shown, correct? But there is one nucleus involved here which gives you the consensual reflex, which Edinger-Westphal nucleus, excellent. Anybody online knows which nucleus? It is the Edinger-Westphal nucleus. So, yes, the right eye optic nerve will send impulse to Edinger-Westphal nucleus of both sides. So that's why you get oculomotor of the other side also getting stimulated and you get the other eye also constricting. Can somebody demonstrate how to show direct and consensual light reflex? Sachi? Use this as a torch. Okay, you can use the phone.
For demonstrating the pupillary reflex, first we'll do the direct pupillary reflex, followed by consensual.
I'll hold it.
So, for this, I will only keep my hand to separate. And if I'm checking the direct pupillary reflex of the left side, simultaneously I will look for consensual light reflex on the right side. I will bring a lighted torch from the distal or the lateral position towards the eye.
Where you will ask the patient to see?
The patient will be looking towards me.
Are you sure? It's best to ask the patient to look at a far away object. Focus on a far away object on the wall.
Okay.
For this, you don't need the child to look at you.
अपने की तरफ देखो.
So you say, I can see the pupil, left pupil constricting.
So when I got the torch, the left pupil was constricting. At the same time, even the right-sided pupil was constricting.
So both direct and consensual reflex is present on the left side. You will do the same with the right side as well, correct? So both direct and consensual reflexes.
Why did Dr. Aditi say that the patient should look far? Anybody online can answer this?
Why should the patient be looking far? What happens if the patient is near a nearby object?
Patient the near object, while accommodation there is convergence and constriction.
Yes. I think I'll have to get used to this online and offline. Correct. So the accommodation you don't want. So the child should be looking far away. Does anybody know what is swinging flashlight reflex or Marcus gun pupil? You may not be asked to demonstrate this, but just to know. I'll tell you. Yes, yes, Dr. Rajiv, I think.
Swing light alternately from one eye to the other eye for 3 to 5 seconds. If there is optic nerve pathology on one side, then the pupil will dilate when the light shifts from normal to affected side. And this test is useful only if there is unilateral pathology.
So what does it detect? So what does it detect? If Marcus gun pupil is present.
Afferent pupillary defect.
Absolutely, very good, excellent. So the right-sided, suppose I have an afferent optic problem, optic nerve paralysis on my right side. When I shine the torch on the right side, no impulse is going to the brain. So this eye is, nothing is happening. But the other eye also nothing is happening because no impulse is going. But my left side is normal. So at this time, when I swing the torch to the left eye, what is happening? This eye is constricting, but even this eye is constricting because the optic nerve is fine. Oculomotor nerve of my right side is fine. Efferent is fine, correct? But now when you swing the light back to this eye, to my left eye or to my right eye, which has an afferent problem, instead of constricting, you will see that this pupil is dilating. Actually, it's not dilating, it's coming back to its original position because it constricted during the consensual reflex. You'll see that it is dilating. This is Marcus gun pupil, okay? So in pupils, you will also later in the third nerve, you should know which conditions do you see pinpoint pupil, which conditions do you see a dilated pupil, this you'll have to read up. And of course, if there is a third nerve involvement, you will have a pupil which is dilated or constricted. Third nerve innervates the sphincter pupillae muscle. If it is affected, the pupil will be dilated. So next is fundoscopy, right? For second nerve, you will do fundoscopy. Again, one more volunteer, please, to check the fundus of Najia. Give it a try, it's okay, even if it's wrong.
Better to try here than in the exam.
That is, so I'll just show everybody before we. So this is the ophthalmoscope, right? It has an aperture for light. In this ophthalmoscope, this is the button to switch it on and off. In others, you'll have a rotating handle here, correct? Which will make it on and off also. This in the center, there is a way you can change the way the aperture looks. So it can be split, it can be circle, it can be a wider circle, it can be a blue lens and all of that. So don't fidget with this in front of the examiner. This is not going to help you. Just make sure that the light is enough and there is a circle. This is, what is this for? Anybody online? No, this is not for aperture.
Resolution.
Adjustment for the light.
Yes, yes. So it is the one which will change the focus. It is the one which is going to compensate with your refractive error or with the patient's refractive error. That also you don't need to fidget from the beginning. After you fix, after you see the patient's pupil, then move it to focus. Okay, then which eye will you hold the ophthalmoscope?
So
Which?
in other words, when we are looking at the fundus, ideally even we need not wear glasses if we normally wear glasses, and patient obviously can't wear glasses. So if there is a refractive error in both or either, and you see a blurred fundus, by moving that you can make it correct because it will take up the refractive error of the patient. That's the purpose of that knob.
Yes. So after you switch it on, you will say that I would prefer the child is sitting in a dark room and the pupils are dilated with a mid-head. Don't fidget, don't do these things. Just say it's fine because the examiner will tick these marks, right? Then which hand will you hold the ophthalmoscope? Which eye of yours and which eye of the patient? Correct? Right eye of the patient, right hand ophthalmoscope, right eye of you. Then देखना है, okay, straight देखना है आपको, ठीक है, आप check कर लीजिए. So again, ask the child to focus at a far away object.
Maybe you can also tell them that एक ही जगह देखो. So you have to identify a far away object and tell them कि इसी पे देखो. Try not to move your eye. And you also specify कि my light will come close to you, but don't look at my light. Keep looking at that far away object.
लाइट पड़ेगा, लेकिन लाइट में मत देखना, ठीक है, सीधा ही देखते रहना. I'll switch it on for you. This is fine. This is fine. Just to show, right? We need a circle. So you change it to a circle. All right. And then you focus with this. After you go close to the patient and look close. Yes. And then look at the pupil. Try to trace the blood vessels to reach the optic nerve head, right? To see the whole of the fundus. Then ask the child if you can see the vessels to look in the other direction to see the other side, right? And the same to be done with the other eye, correct? Now, one of the common OSCE questions that is asked is, this is a normal fundus and what are the different parts? So can somebody tell me somebody online tell me what is this? A?
Optic disc.
What is this? B? Enter of the
Fovea
optic,
centralis.
the optic
Fovea
cup.
centralis.
No, that is not the
Optic cup.
fovea.
Optic cup.
Very good, optic cup. What is this? C?
Macula.
No, that is the fovea, and surrounding it is the macula. And of course, there are blood vessels. The ones which are tortuous and big are veins. Straighter and smaller are arteries, right? So this is the normal fundus. How will this question be followed in the OSCE? Second question will be, how will you identify a papilledema? Anyone?
Blurring of the optic margin of optic disc.
Yes, and?
And disc hemorrhages.
So there is mild, moderate, and severe.
So there will be loss of the physiological coupling, optic coupling.
Yes, yes. And, in this moderate grade, there'll be elevation of the disc, right?
Yeah.
And in the third grade of the severe, not 1, 2, 3, it's more like mild, moderate, severe. What will you see? Everything, yes. Hemorrhages, microexudates, infarcts. That is the severe grade of papilledema. The second question that can be asked, how will you identify optic atrophy? What will the disc look like? Pale, yes. And there is one more sign, I forgot the name of that sign, where if you trace the number of vessels which leave the margins of the optic disc, it's usually more than 10. If it is less than 7, that is one more sign to say that this is possibly optic atrophy. So this kind of question can be asked in the OSCEs. Again, you know, for field of vision, this is again very commonly asked question. What you can remember is that the fibers on the nasal side of the eye see the temporal side. The fibers on the temporal side see the nasal side. Only the nasal fibers decussate. The temporal fibers do not decussate. Once you know this much, you will know which side the lesion is. I remember it this way, since only the nasal fibers are decussating, and if the lesion is at the optic chiasma, both side temporal field of vision will be lost. Opposite side. So this is heteronymous hemianopia, right? Everywhere else, only the same side. So if I have my right temporal vision gone, my left nasal vision is gone, the same side. Everywhere else, that is a homonymous hemianopia, correct? So everywhere else, if you see from here down, there is a homonymous hemianopia. Only in the lesion of the optic chiasma, there is a heteronymous hemianopia. And of course, if there is optic nerve, complete blindness on that side. So you can be asked this question again in the OSCE by fill in the blanks, okay? Which of these is which one? Next, how to test the third, fourth, and sixth cranial nerve. So let's see ptosis. Third nerve palsy causes ptosis. Can you tell me why? Yes. Perfect. Levator palpebrae superioris is affected, correct? So if you see this child, this eye has ptosis, the right eye. Now here you have to see that the cornea can be seen down, correct? If you ask the child to open his eye, he will use his frontalis. There will be wrinkling, extra wrinkling to try to open his eye. So this is an inability to close the eye. Which nerve causes inability to open the eye? Correct? This is inability to, sorry, again, I made a mistake. This is inability to open the eye. The levator palpebrae is affected. And seventh nerve is inability to close the eye, correct? Now, eye movements. So you know this formula SO4 LR6, the superior oblique is supplied by the fourth nerve, lateral rectus by the sixth nerve. Which other muscles are left? Superior rectus, inferior oblique, medial rectus. They are supplied by the, can anybody tell me what is the action of superior oblique?
Outwards, downwards and inwards.
Inwards,
Depression,
right? It is a pulley muscle. Yes, yes. Anybody online knows?
Depression and abduction.
Yes. So it moves the eye downward and inward. Both obliques are going to be inward. Superior oblique will be downward and inward. Inferior oblique will be upward and inward, right? Now, if the paralysis of the third nerve alone is present, the eye will be rotated outward and downward. Outward and downward. It's never going to be alone, but this is just that you should know. You will never see just one third nerve involvement like this, but sometimes you may. Now, suppose if the fourth nerve is affected, so superior oblique is gone. Superior oblique turns the eye. So if it's not inward and downward, what will happen?
Outwards and upwards.
Correct. So when the fourth nerve is involved, the eye will be outward and upward. What will happen if the sixth nerve is involved? Because the lateral rectus is affected. Now, sometimes you may not see these frank positions of the eye, but you may have to elicit them by checking the eye movements. So let's see this video.
You want them to do the movements on
Yes,
the
yes, yes.
patient?
Yes, yes, I'll just show this video to see you. Okay, I don't think the video is working. So can you show me how to check eye movements? No. The patient has to be looking at your finger, right? So no need of focusing.
Can you cover your मतलब एक हाथ से यूं पूरा अच्छे से कवर करोगे ऐसे पाम थोड़ा सा ऊपर एक बार आपके जो मेरा फिंगर है ना उसको आपको फॉलो करना है अपनी सर नहीं हिलाना है सिर्फ आंखें हिलानी है जैसे देखो मैं यूं अपनी सिर्फ आईज हिला रही हूँ ना वैसे सर नहीं हिलाना है ठीक है फॉलो करना है पूरा अच्छे से.
It's a good idea to even stabilize the head. And actually there's no need to close one eye also. Yes, yes. You can do that. You can see both eyes movements. So what are the cardinal positions?
From center to right, then center to left, then upwards
And downwards. Do it.
Follow.
Don't keep so close. The patient is.
So as Aditi said, use your left hand to
Stabilize.
on her head to stabilize the head, not neck. Upar rakh.
Upar, हाँ.
Follow करना है ना.
Correct. So left, opposite side, up and down. Don't get too close because she starts accommodating. Right? And then what are the?
Diagonal side.
Yes. So how do you do them?
Horizontal.
Put your finger straight. That's fine. So ideally, it is very difficult for the child to see only diagonal. So you should go along the box, okay? Up, down, left, right, and then go along the box. It's difficult to see like this. So when the eye is lateral, going up and down is the action of the obliques. Okay, so this is how you check the eye movements. Now you may be asked to do a cover uncover test and alternate cover test. Quickly, I'll just tell you, can anybody tell me what are the two types of squint? Paralytic and non-paralytic. Paralytic is obvious, you can see it. And it can be monoocular or alternate. So what do you do in a cover uncover test? Okay.
Someone online, what is cover uncover test?
Cover test, this is a test for actually lateral squint, where the squint is not evident on neutral gaze. Here we have to ask the child to look with both eyes at my right eye, and then cover his left eye. Then uncover his left eye rapidly and cover the right eye. Look to see if the left eye has to correct to look back at my eyes, and repeat covering the left eye and watching that right eye. If one eye has to correct as it is uncovered, then this indicates that the child might be having a lateral squint.
Yes. So I think more or less everything you covered. Now here what you have to do is, before doing the cover uncover test, always check the position of the eye movements in all. If it comes in the exam, even if it is not given, check the eye movements. Beta mere ungli ko dikhna, huh? And of course you'll be stabilizing the head. Correct? After you check that there is no paralytic squint, then only you can do the cover uncover test, right? If you already have a paralytic squint, you are not going to do. Suppose I'm using this for cover. Okay, beta, aap meri taraf dekhna, or what else you can do is ask the child to focus on a nearby object. Correct? Because the focusing is important. Only when the child is focusing, I'll know if the focus is getting disturbed. So I'll cover one eye and see if I can see any sudden movements in the uncovered eye. Suppose while I'm doing this, I have covered my left eye and my right eye quickly moves inwards to focus. So what is the problem? The right eye was a little outward. Anything outward coming in, outward is exo, inward is ezo. So this is my right eye has a exotropia, correct? We'll uncover and see if that eye again goes back to that original position. Same thing you will be repeating on the other side. So this is the cover uncover test. And what is the alternate cover test? It is used, beta ye mic ko dekhte rehna. Sorry. And then आपको इस पेन को देखना है, ठीक है? And then you keep doing this. While you're doing this, you check if there is any change in the movements of both the eyes. So if there is an alternate squint, both eyes will be moving. This helps in breaking the fusion. This helps in bringing out hidden forias. And this helps in finding the magnitude. How much is the eye moving? Not very important, may not be asked, but if at all it is asked as a question in the exam, what are the tests for squint? You should know.
Will be moving normally.
No, so if I don't have a foria or a tropia, there'll be no movement at all. Yes, but if I'm doing cover uncover, every time during focus, my both eyes will be moving depending on which side is the problem. So you'll know whether this foria or tropia is monoocular or biocular. You will know how much is the distance that the eye is moving. So magnitude of the foria. And the principle behind this is to break the fusion of the two axes. Now pupils we already discussed, right? Then coming to test to break the fusion, yes. So test the fifth cranial nerve. Now I think we'll go a little bit faster. Can somebody test the fifth cranial nerve of this patient? Okay, I'll say quickly, then you check. First, you'll be asking the child to clench her teeth. Which muscle are you checking? No. Masseter, right? How will you show? दोनों दांत एक दूसरे को टच करके जोर से दबाओ. Correct? And when the child is doing that, you can also feel the muscle. Okay. The next thing is ask the child to open the mouth wide and see which side the jaw deviates. Normally the jaw will not deviate to any side. So you ask the child to open the mouth wide. Very good. Okay. ठीक है, बंद करो. If there is a problem in my right sided trigeminal nerve, which side will the jaw deviate? Same side. But why? If my right sided nerve is defective, I should not be able to pull the jaw on that side, right? Of the, absolutely correct. Perfect. So the pterygoid muscle action is to push the jaw to the center. My other pterygoid is fine. So it is pushing the jaw to the center, but crossing. So here in the fifth nerve, the jaw deviates the same side of the lesion. Sometimes it's difficult to make that out because it is associated with the tongue as well as the other movements. But this is what you should know. Which reflexes will you check for fifth nerve?
Jaw reflex.
Yes, somebody said corneal and jaw jerk, right? So for corneal, how will you check? It's okay, don't check now. At the cornea. So the patient feels the sensation on the cornea because of the fifth nerve. But blink is because of what? Is the fifth nerve responsible for the blink? Which nerve blinks? Seventh nerve, right? So we are checking the corneal reflex, fifth and seventh, both indirectly. But fifth more important because unless the child has the sensation, he is not going to blink. And jaw jerk, correct? Sensory, can you tell me the three divisions of the trigeminal nerve for sensory innervation? Ophthalmic or frontal, whatever you want to say. So you have to check in all the three areas for sensations of, you can also check for temperature, touch in these three areas. So that is sensory. The next is how to test the seventh nerve. Somebody else, please perform motor. This is the most important nerve, right? Motor nerve, motor component of the seventh nerve. I will not disturb you in between. Say, do the whole thing.
मैं खोलने की नहीं, ऐसे नहीं, ऐसे बंद रखो. मैं खोलने की कोशिश करूंगी. आप ट्राई करना, नहीं खोलो. अगर आप नहीं खोलोगे तो प्रॉब्लम.
So always, wherever you can demonstrate. So you close your own eyes tightly and show कि ऐसे बंद करो. Then it's very easy.
खोलेगा तो नहीं खोलेगा ना. बेटा ऐसे wrinkling करके देखो, ऐसे करके ना.
आंखें ऊपर करो.
ऐसे.
Eyebrows ऊपर करो.
Eyebrows.
And then say, I am trying to look for wrinkling on the forehead of both the sides.
So the frontal is
yes, yes.
And that I check
closing oculi. Third,
meter I look for.
how will you do that?
Beta ऐसे करो.
And see if there is any escape of air. Fourth.
So in this, when you are telling them to blow the cheeks, just blowing is not enough. How do you look for power in the limbs? So here also you have to check against resistance. So when they blow, you have to see whether you can burst that bubble types. Okay, that tells you the power of the muscle.
Most important. Angle of mouth, you'll see, ask the child to smile.
If there is any loss of nasolabial force.
And if there is any deviation of angle of mouth. And fifth, you ask the child to evert the lip. Beta, ye karo. And check for the, she's doing it really well. She's a very cooperative patient. Thank you. And check for the, which muscle? No, platysma. Correct? So 5 muscles. Now, if my right-sided facial nerve is involved, where will my angle of mouth deviate? When I'm smiling?
It's the same side. So 7th now. So opposite side, because it's the same.
Don't think like that. Imagine if you're smiling, if my these side muscles are not working, my angle of mouth will deviate to the opposite side, right? Jaw, you know why it is deviating to the same side, but angle of mouth is deviating to the opposite side because the opposite side is normal. This side is not able to smile. Okay. Sensory, what will you check? Of anterior 2/3 of the tongue. And just remember there is parasympathetic nerve supply also. So ask the child or ask the mother if there is any proper lacrimation and salivary gland secretion. This I just put up for you all to just how I remember it, because I always find it difficult to remember this part. See, right and left, right facial nerve nucleus, left facial nerve nucleus. Okay. The right upper half supplies the upper half of the face, left lower half of the face. I mean, right, the right side, left, the left side, but upper part of the nucleus for upper half of the face. But see what is happening to the cortical fibers. See, the right-sided cortical fibers are going to the right-sided upper part of the facial nerve nucleus. They are also going to the left side. What is happening to the left side? Going to the left side upper part, also going to the right side. So if right upper part of the facial nerve nucleus, it is innervated by both sides. So the upper half of the right side of the face is innervated by both sides. Okay. This concept is clear. See the lower part, lower half of the right side. It is receiving from the opposite side. Opposite side. Opposite side. Okay. See what is happening to the lower half of the left nucleus. It is receiving fibers from the right side. This is clear. Now just imagine if there is a lesion above the level of the right facial nerve nucleus. Where is the right facial nerve nucleus? Pons. Somewhere between the pons and the midbrain, suppose there is a lesion on the right side. Now look what is happening to the right facial nerve nucleus. Is it getting affected? It is receiving nerve supply from the opposite side, both upper and lower. So the right facial nerve nucleus is not affected for this right-sided lesion. What is happening to the left nucleus? The lower half is not getting supply from the affected side. Upper half is receiving. So in this patient, what will happen to the face? The opposite side of the face, right? Because we see the opposite nucleus is involved. Isn't it? You saw the right nucleus is not affected. It is getting nerve supply from the left side. But the left nucleus, lower half is getting affected. So the lower half of the face is getting affected. What does this mean? In supranuclear facial palsy, only the lower half of the facial face is affected. Upper half is not. Why? It has a supply from both the sides. Let's see this picture. Okay, right, left remains the same. Don't get confused. What will you see in this child? Both eyes will look okay. Wrinkling of the forehead will be okay. But his angle of mouth will deviate to the right side. Opposite side. Angle of mouth deviates to the opposite side. So in this child, the angle of mouth of the left side is not deviating. That is the side where there is a problem. Barabar? Suppose there is a lesion in the left pons. Look at this picture. This facial nerve nucleus is affected. What is it supplying? Correct? Same side of the face, up and down both. So in this nuclear or infranuclear lesion of the facial nerve, whole of the same side half of the face is involved. So what will this patient look like? If this is a left facial nerve nucleus, I told you, left nucleus supplies the left side. That you don't forget. So what will happen to the left eye? It cannot close. It will look big. And which side will the angle of mouth deviate? Right side. Correct? So by this picture, do you understand that this is a lower motor neuron facial nerve nucleus, facial involvement? Because both the upper and lower part of the face is involved. Is this very complicated? You'll have to read it again to understand. Now, just one more thing here. Suppose in this child, I tell you that this eye which is not able to close, the cornea is shifted medially. Which nerve? Lateral rectus is affected. Same side, because same side, same nucleus, right? So right side eye is not able to move laterally. So right-sided lateral rectus, so right-sided sixth nerve, along with the right-sided facial nerve. Now, if there is a left pons gone, which side will be the hemiplasia?
Have the pyramidal fibers crossed yet?
Right side.
So pons is above the level of the medulla where decussation of pyramidal fibers is taking place. Opposite side. If the left pons is gone, I have hemiplegia on the right side. And I have facial nerve involvement on the same side. Uncrossed hemiplegia. Crossed hemiplegia. Left facial nerve nucleus gone. Right-sided hemiplegia. Left-sided lower motor neuron facial nerve involvement. Crossed hemiplegia. So just remember, when there is a crossed hemiplegia, it is at the level of the nucleus or below, but above the decussation. Okay. Now, just because I never remember these names, I thought I'll put up. So ipsilateral third nerve, midbrain, right? Suppose left third nerve is involved and right-sided hemiplegia. So contralateral hemiplegia is known as Weber's syndrome. Correct? Crossed. Same thing with cerebellar ataxia as Benedict's. 6th, 7th nerve with contralateral hemiplegia, which we spoke about. That is Millard-Gubler. 9th or 10th nerve on one side and other side hemiplegia is lateral medullary syndrome. 12th nerve and contralateral hemiplegia is medial medullary syndrome. Now, this is impossible to remember, but you all can read it just before the exam. What is more important is to pinpoint where the lesion is likely to be. Okay. So to know where the lesion, I just want you all to remember a few things. When you look at the face, you have to answer these 4 questions. Which is the problem side? Left. The angle of mouth is deviating to the right side, so left side is a problem side. Is it upper motor neuron or lower motor neuron? For that, you have to see the upper half of the face. This is a lower motor neuron. So left side is involved. So where is the likely site of the lesion on the left side? Correct? Same side. And which side will the hemiplegia be? Opposite. Correct? Suppose if this patient doesn't have a hemiplegia, that means that the nerve is damaged after it has exited the stylomastoid foramen. What is that known as? Correct. So let's apply this for this patient. This can come as an OSCE question. They will put this picture and say, identify which nerve is involved, what is the cause, and how will you treat? So let's see those 4 questions again. Yes, sir? Okay. So somebody online, can you tell me which side is the problem side? See, this child is not smiling, so it's a little difficult, right?
Left side.
Yes, the left side, because the left eye is unable to close. Now, how do you know this is not a ptosis? See, the child's cornea is going up. What is this phenomenon known as? The cornea goes up when the child is trying to close the eye. It's a Bell's phenomenon. Bell's, yes. So the left side is a problem side. Now, is it upper motor neuron or lower motor neuron?
Lower motor neuron.
Lower.
Correct, because the upper half of the face is involved. You can see, it doesn't matter which side the eye deviates. If the upper half of the face is involved, it has to be lower motor neuron. If I ask this child to smile, which side will the angle of the mouth deviate?
To the normal side, right side.
Yes, to the right side. So the lesion is on the left side or the right side? Left side. And suppose if I tell you this child came walking to the clinic, then you know that this is after the nerve has left the stylomastoid foramen. There is something known as hyperacusis and chorda tympani, but we'll not go to that. That is useful for knowing whether the cranial nerve is affected just after it has left the stylomastoid foramen or just before, but I think we'll not go into that. Another face. So faces look different, right? That's why follow these 4. Somebody online, this is a newborn who had a difficult forceps delivery. Which is the problem side?
Left.
Left side.
Left side.
Loss
Mostly
of nasolabial
no
fold.
child cries with one eye open, right? So yeah, this looks like the left side is problematic. There is also angle of mouth deviating to the right side. So this is a left lower motor neuron facial nerve, mostly because of forceps injury. We don't know that because the movements of the eyeball cannot be appreciated at this age unless you do the movements of the normal eye also. Now, this is one of another OSCE question.
Tilting of the mouth is towards the left side. Because eye is to be this side.
But both eyes are closing.
Yeah.
Then
Right
Human
side
pulse.
lesion, upper motor
Human
neuron.
right side.
anybody online?
Upper
The right
motor
side
neuron,
human
right
pulse.
side lesion.
Absolutely. The eye is fine, right? So this is congenital absence of depressor angularis oris muscle. The left side where the muscle is absent, the lower lip is going down. Angle of mouth is not deviating. Correct? There'll be drooling of saliva from there or drooling of milk from there. DA, depressor angularis oris muscle. It is associated with congenital heart in some cases, so we ask for an echo. How to test the eighth nerve? Anybody tell me, please, Rini's test? We don't have a tuning fork, but just assume that this is a tuning fork. You know? Anybody online knows how to do Rini's test?
Sachi is demonstrating.
Okay, okay.
Doing the Rennie's test, we assume the principle is that the air conduction is better than the bone conduction. So we'll take the tuning fork, preferably 512 hertz tuning
Very
fork
good.
we use. We hit it on the rubber pad so that it starts vibrating. And first we'll put the vibrating tuning fork on the bony prominence behind the ear of the child.
First, you make her hear what it sounds like.
Like first we'll tell her like what it sounds like. So like once she recognizes that sound or feels the vibration when kept on the bony prominence, like we'll keep it on the bony prominence and tell her if once she stops listening to it, then we'll get it in the front and tell her if she can still hear it. So like I demonstrated now. So like after hitting
So, you know,
on-
you can do the air conduction first, and when she stops hearing, then put it on the bone. Okay? She should not be able to hear it then in a normal ear.
So, like as you said, ma'am, first we do for the air conduction, and once she says that she's not hearing that sound anymore, then I'll put it on the bony prominence for her to understand that.
So what does Rini's test show?
In a normal-
Suppose if the bone conduction of this side, she can still hear.
that will indicate a conductive hearing loss.
Correct? That is a conductive hearing
The
loss.
air
Very
conduction
good.
is affected.
Do the Weber's also then.
In Weber's test, after hitting the tuning fork, we place it in the midline, usually on the forehead, and we'll ask her that if she can preferentially hear it on one side, like if there is a lateralization.
आपको कौन सी बाजू कान में सुनाई दे रहा है? हाँ? So she will not tell you anything different because ideally, normally.
So she will not have any preference to one side.
Correct.
It will be equally heard on both the sides.
So what happens if I have a right-sided conductive deafness and I put a tuning fork on the forehead? Which side will I hear it? Right-sided conductive deafness. Put the tuning fork
Lateralized to the better ear.
to the no,
Right side, same
to the
side.
same side. Why? Because that side bone conduction is fine. Only the air conduction is affected. But if I have a sensory neural deafness in my right side, somebody online can answer this. If I have a sensory neural deafness on my right side, where will the Weber lateralize?
To the left side. To
To the left side,
contralateral
normal
side.
air.
This side, to the normal side. All right. But if there is a bilateral sensory neural, you cannot use this test. Now, I thought I'll put Romberg's here, but can somebody tell me Romberg's is a test for what? Sit. You can sit with the mic on. Is it a sign for cerebellar dysfunction?
No, ma'am.
Posterior column.
Yes. So yes, somebody online also said it is a sign to find dysfunction in the proprioception, dorsal column, sensory ataxia. It is not a sign for cerebellar dysfunction. Now somebody please perform Romberg's for this child. Yes, Aditi. बेटा आप खड़े रहना हाँ? हाँ, okay, yeah, just stand this way, I think. बापा ऐसे खड़े रहो.
ऐसे करो और मैं जब बोलूंगा ना आंखें ऐसे बंद करो.
No, this is not the regular rhombox. Where, how will the legs be?
Together and close to each other.
Correct, V shape. Stand straight, both hands by the side, eyes open. Correct? She will not sway. Then you ask her to close the eyes. And then how long will you observe her after she closes the eyes? If she doesn't, how long? So there is a criteria for this. 1 minute. You have to observe the child for 1 minute after the child closes his eye, because there'll be a little bit of swaying in order to get that balance right. Correct? In 1 minute, if the child falls or tries to move towards one side and loses balance, that is a rhombox sign, positive rhombox test. That indicates there is a defect in the proprioception. Initially, the vision was helping the child to stand straight. But when the vision was removed, the child was not able to stand because proprioception could not be maintained without the assistance of vision. All right. If the child does not fall, but the child has ataxia, that means it's not because of posterior column, not because of sensory ataxia, then you think of cerebellar. Then you do the other tests of cerebellar dysfunction. But rhombox itself is not a sign for cerebellar dysfunction. Is this understood? Sit. Just make her sit up. Okay, 9th and 10th now. Yeah, gag reflex. So 9th is the afferent and 10th is the efferent. When you touch the posterior part of the pharynx, what happens in gag reflex? Close the mouth. Cough, is that gag? What happens, somebody online, what happens in gag reflex?
Contraction happens of the muscle and upward and anterior movement.
Yes, so that contraction and the tongue moves in. The action of how you would want to vomit, right? That is a positive gag reflex. And sensation on the posterior 2/3 of the tongue, right? That is for 9th and 10th. 11th, now you'll check the trapezius. So somebody check the trapezius and sternocleidomastoid of this patient. Come on, you'll try. आगे से भी कर सकते हैं. So first show her what you are going to do, then put resistance. पहले ऐसे ही करो बिना प्रेशर के. Just tell her to shrug her shoulders. हाँ, excellent. See, she understood it better. Now put it down. अभी बेटा आपको जोर लगाएंगे, फिर भी आपको वही करना है. हाँ, अब दिखाओ आप कितने strong हो. Right? What are you checking? Which muscle? Yeah, right. And how will you check the sternocleidomastoid? But yes, that is, you can see that muscle, but how will you check it? You will ask the child, correct, to look on that side against resistance. So, बेटा मेरी तरफ देखो. हाँ, इस तरफ आप सर घुमाना. ठीक है, अभी यही करना है, मैं जोर लगाऊंगी. ये साइड आपको सर घुमाना है ऐसे. हाँ, करो. Oh wow, so powerful, so strong. So you are checking the sternocleidomastoid of this side. Same thing with the opposite side. Okay. And the 12th nerve, you will be checking the tongue, the shape of the tongue, fasciculations, if there are any tremors, movements of the tongue, and ask the child to protrude the tongue. What will happen if there is a 12th nerve palsy? The tongue will move to the same side. Just remember same order, right? 5, 7, 10, 12. S, O, O, S, same, opposite, opposite, same. But this is for remembering, but you understood why this is, right? Why this is. The tongue is moving because the action of the tongue muscles to while protruding is to bring it to the midline. So that side muscle is affected. It will move to the same side. So I'm just putting up a few questions which I found, which were asked in OSCEs related to this topic. So a picture of Bell's palsy patient is shown, which you saw, right? And then questions are asked, how will you find which nerve is involved? What is the etiology? How will you treat? Will you be able to answer this question? If you look at a Bell's palsy, you'll be able to answer. Demonstrate the examination of the seventh cranial nerve. Can you answer this now? Perform Romberg's test. So the normal fundus, identify all the parts, and how will you identify optic atrophy and papilledema? Sometimes the question can be a little different. It can be this child, examine this child who presents with diplopia. It will not be just examine third, fourth, sixth nerve. But you should know that when you are examining a child with diplopia, you look at third, fourth, sixth. Something like this, a case is put. Big infected nose pharyngeal, after 5 days presence with fever, altered sensorium, diplopia, and a video pic is shown, third, fourth, sixth nerve are involved. What will you think of? Yes, right? How will you diagnose? How will you treat? The optic pathway, you will have some questions asked on that. Explain the types of squint, what tests are done, and what is bulbar palsy and how will you differentiate from pseudobulbar. So bulbar is involvement of the 9, 10th, 11, 12th medulla. And pseudobulbar is upper motor neuron control of these nerve nuclei, correct? So whenever there is pseudobulbar, it is an upper motor neuron. So jaw jog will be exaggerated. So I think that covers all the nerves.
Thank you. Now we move to the second part for today, which is the case presentation. And we don't have this particular child here today, but we will just go through the case presentation and see how to discuss. Yeah.
Just call Nilesh. Sorry, Vinod, any one of them. Vinod actually. कॅमेराज असंच ठेवायचे आता. आता फक्त केस प्रेझेंटेशन आहे. तसंच राहील ना? ठीक. नाही मग ही चेअर इकडे घे. इकडे. हाँ हाँ प्रोजेक्टर बंद कर.
My patient, 2-year, 10-month-old male, Virat, first by birth order, second degree consanguineous union born, presented with complaints of distension of abdomen since last 10 months. History of present illness. The parents noticed that the abdominal distension was insidious in onset and gradually progressive over last 10 months and generalized in nature. However, it did not cause any pain, discomfort, or breathing difficulty. There was no lump noticed in the abdomen, though the parents noticed that he was not gaining height as fast as his peers were since 1 year of age. The appetite is good, activity and playfulness is intact. There is no history of jaundice, clay-colored stool, or high-colored urine. No history of petechiae, purpura, loss of appetite, or not gaining weight. No history of hematemesis, melena, or lump in abdomen. No history of pallor or blood transfusion. And there is no history of short stature in the family or delayed attainment of height in family.
How old is the child?
2 years, 10 months, sir.
कौन?
So, birth history, no significant antenatal history, no history of fever, rash in mother, or there was no other illness in mother during the antenatal period. The child was born by normal vaginal delivery and was a full-term baby. Birth weight was 3 kgs. There was no history of NICU stay or any significant illness after birth. Immunization is complete till date. and dietary history is unremarkable. So as per socioeconomic, the child belong to lower middle class as per modified Kupus-Mummy scale.
So what do you make out of the presenting complaints?
So here I have a child of 2 year 10-month-old who is having a progressive abdominal distension since last 10 months, and it is generalized in nature. So if we go to our causes of abdominal distension, then among the 5 apes, that is fluid, fetus, feces, flatus, and organomegaly. So among them, fetus and flatus and feces are unlikely. Then we come to the history.
Why feces is unlikely? Classic age for functional constipation.
Yeah, because there will be a history of relief of the distension after passage of stool, and there will be a waxing waning course.
Okay.
Yeah. And so we are left with organomegaly and fluid. So if we look into the progression, it was gradually progressive over last 10 months. So that is more likely to be due to organomegaly, because if it is a fluid or ascites, then the history will be the progression will be the distension will progress for some time and then it will be static. So and progressive organomegaly seems more likely here.
Can it be just hypotonia of the abdominal wall? Suppose this child is undernourished and it is hypotonia of the abdominal wall.
Sir, if the child will be undernourished, the primary complaint of not gaining weight will be there.
They may not have noticed it, no?
But only hypotonia of the abdominal wall.
Yeah, meaning abdominal wall hypotonia looks like distension, no? That's the thing. Anybody online wants to answer? Can it be hypotonia of the abdominal wall? So hypotonia of the abdominal wall is never progressive and it will change even according to position. So when the child lies down, the distension will no longer be visible because the abdomen will become flat. Okay. So that is why it is not that. Okay. So you said that this is basically organomegaly.
Going into organomegaly, so if we see that it can be.
Yeah, one more thing is in your history, you said that they have noticed that he is not growing in height. Frankly, in a 2 year, 10-month-old child, noticing that he is not growing in height for last 1 year is a little difficult because it's an age at which it's not easy to make out a change in height so much. So be careful, or at least say that it's on direct questioning. Okay, go on.
We further look into the organomegaly. So it can be so isolated splenomegaly can't present as distension of abdomen. It will more likely be a lump fill in the abdomen. So we are left with either hepatomegaly alone or hepatosplenomegaly, which is coming with distension of abdomen. So I'll confirm my hypothesis on examination.
Okay. So you think this is likely to be hepatomegaly or hepato plus splenomegaly. Now, Sachi, what are the possible reasons for this on history, based on the history?
So as Sauradeep said, it can be either only hepatomegaly or hepatosplenomegaly. And like he said, for the negative history, that there is no history of jaundice or hematemesis and no history of any blood transfusion in the past. First, I would like to keep storage disorders as one of the differentials.
So before you jump to storage disorders, it's better to talk about that whether when you said hepatomegaly or hepato plus splenomegaly. So hepatomegaly is there in both. Now you talk about the 4 components of liver disease. So you try and discuss whether it is hepatocyte disease, etc., etc. So you want to tell us that?
Liver pathology can have 4 components. If it is a hepatocyte involvement, the child will present with signs of liver cell failure, including jaundice and ascites may be present. The child will be more sick if it is hepatocyte involvement. And if it is a reticuloendothelial system.
So again, a better word is not liver cell failure, but hepatocyte dysfunction. Because failure is at the end. So you want to know whether there are any signs of hepatocyte dysfunction.
Yes,
Okay.
sir.
So that is one. What are the signs of hepatocyte dysfunction? You said one is jaundice. Anything else?
Loss of appetite,
Okay.
growth failure. I mean, not gaining weight. And then
So now what is the difference between growth failure and this child? You are saying that they have noticed that he is not gaining in height. So that is growth failure.
So the child will not be gaining weight also. If it is a hepatocyte involvement, the child will have failure to thrive and the parents will notice that the child is not gaining weight before they notice that the child is not gaining height.
Sure. So here, if it is specifically not gaining height, then you will have to ask whether the weight is okay. Okay. Otherwise, it could mean hepatocyte dysfunction, chronic hepatocyte dysfunction.
Yes.
Then this is one component, hepatocyte dysfunction. What else?
Biliary component.
So that's possible in this child?
No.
Sir, only biliary component is unlikely.
Why?
Because the principal complaint is deep jaundice in biliary. So absence of jaundice makes biliary component more unlikely.
Less likely.
So you cannot have a biliary component, biliary disease without jaundice. Okay, so therefore that is ruled out.
Yeah.
They have not seen it unless you pick up pictures on examination. Then
Vascular and reticuloendothelial
okay, so
component.
1 minute. Why is this not vascular?
So what do we mean by the vascular component? What do we mean? Give me an example of a liver disease which is because of involvement of the vascular component. Budd-Chiari. So actually anything that causes portal hypertension is a vascular component, correct? Now, can this be that? Hold closer.
No hematemesis and no melena history.
True. So now, does absence of hematemesis rule out portal hypertension? No. So there can still be portal hypertension, right? So that's not your strong reason. Okay. So can this be vascular component or it cannot be?
Chronic condition, matlab more than 10 months has happened, less likely to be a vascular cause because they are generally an acute presenting condition.
So let me ask you the other way. You said Budd-Chiari is a prototype of the vascular component. So in Budd-Chiari, are there strong symptoms and signs of hepatocyte dysfunction?
No.
No. So this child doesn't have. So he's otherwise a okay looking child on history with just progressive abdominal distension. That distension could be hepatomegaly plus fluid.
Yeah.
We don't know.
Yeah.
So therefore, at this stage, vascular component is possible because there is usually not a great hepatocyte dysfunction in that. Okay. And last is your reticuloendothelial. So can this be that, Ayushi?
An involvement involving both liver and spleen. It can be.
So tell us the various groups of reticuloendothelial involvement and try to say which one of those is possible here and which one is less likely?
Storage disorder can be one of the things.
Okay, so storage disorder, and it is possible or unless likely?
It is possible in
Okay, then,
infection, maybe it's possible if it's a malaria involvement and can be there.
so what is missing to call it an infection?
Generally, for infection, it has to start with a fever component and
So in 10 months, there has been no fever at all. So that goes strongly against infection. So which infections cause hepatosplenomegaly by virtue of reticuloendothelial enlargement?
malaria, TB can be one of the
Okay, so malaria, TB.
and brucellosis can
So
be
any chronic infection like brucellosis, kala azar.
and typhoid.
So 10 months typhoid you will not mention, right? Okay. So therefore, basically you will say that because of no fever, all these infections seem less likely. Okay. Can it be infiltration?
Infiltration, it can be.
So can it be leukemia or lymphoma?
So, if it is 10 months history, only abdominal distension will not be the presenting feature. The child will present with other feature, like if it's an ELL, they will present up leg pains, and the child is absolutely, otherwise the child is not a sick child. In 10 months, the child will develop sickness in leukemia or lymphoma cause.
So leukemia can be ruled out. Can lymphomas be also ruled out?
No, lymphoma is still a possibility.
It's still a possibility.
So lymphoma is still a possibility, right? Then what are other conditions which are kind of like a leukemia, lymphoma, but not as fulminant? So histiocytosis, okay? So such things are possible which can be little slower in progression, okay? So neuroblastoma, what are your points for and against?
Abdominal distension.
So abdominal distension in neuroblastoma is usually due to what?
They were involved. Mass. It's because of the mass.
It's because of a mass. So patients will come to you for a lump in abdomen rather than generalized abdominal distension. Okay, fine. So these are your thought processes about this possible hepatosplenomegaly on history. Now, how do you put in the short stature?
So, in some storage disorders, in some storage disorders short stature is a complaint, a feature. And
so can this be hemolytic anemia? They also grow less and they can have hepatosplenomegaly.
Yeah.
Anybody online wants to answer whether this can be hemolytic anemia? Have everybody disappeared from online?
No.
Yeah, tell us. Can it be hemolytic anemia?
No, sir.
Why not?
Examination
Because if it is transfusion dependent hemolytic anemia, then child will have the history of both. And if it is non-transfusion dependent, then child will have the hemolytic history.
Okay, hemolytic phases you will not pick up on history. So you have to
There is
tell
no
me which
jaundice.
non-transfusion dependent anemia can come at 2 years, 10 months with a distension of abdomen.
Sickle cell anemia.
So does sickle cell have massive hepatosplenomegaly?
No.
No.
They will sickle cell.
Okay, sickle thal.
Yeah.
So therefore, what you will say is that it is very unlikely to be transfusion dependent because they will not survive without at least one transfusion till this age, right? Amongst the non-transfusion dependent anemias, what remains is your beta plus thal, that is thal intermedia, or some combinations of sickle thal. But again, what will be the chief complaint? Parent should have noticed pallor.
Yeah.
Okay. And its consequent effects. So poor activity or reduced playfulness or whatever. So all those are not there. So therefore it is quite unlikely. So therefore after history, what are your differentials?
So my differential, first one will be a storage disorder. Second one will be chronic hemolytic anemia or a mixed chronic hemolytic anemia or a mixed hemoglobinopathy like sickle cell and thal intermedia. And a distant third possibility will be chronic reticuloendothelial cell involving infections, though the possibility seems very unlikely.
Lymphoma can be one of the.
So anybody else wants to give a different differential or different order of the differentials?
Then chronic mixed hemoglobinopathy. Then I'll go for the lymphoma part, and then a distant one will be the infection.
So I would say that in 10 months, if there are no fevers and no other complaints, I would actually not talk of infections. So therefore, storage is your first differential. Then the second one, instead of chronic hemolytic anemia, we talked of the vascular component, but Chiari prototype, which is quite possible. They will have only distension and you may pick up other subtle things on examination. Then your third, you actually say against, you talk against. So chronic hemolytic anemia is unlikely because there is no pallor, but I will recheck that on examination. And infections are unlikely if the history of weight gain, which is not affected, history is only of height affection. So if that history is accurate, then chronic infections are also unlikely. So you are left with only these two differentials, right? Okay. Now on examination.
So on a general examination, the child is alert, comfortable, lying on mother's lap and conscious. Vitals are normal and unremarkable. Then there is no icterus, clubbing, edema, lymphadenopathy present. Mild pallor is present. Hemolytic facies is not noticed. There is no frontal bossing or malar prominence. There is no signs of liver cell failure like spider nevi, angioma, or fetal hepaticus. There is no dysmorphism. Then on systemic examination, parabdominal, on inspection, the abdomen looks distended. The umbilicus is everted. There is no scar or tap wound. Flanks are full, and hernial orifices and genitalia are normal. Then on palpation, superficial palpation, no tenderness, girding, or rigidity present. On deep palpation, liver is enlarged, palpable, 8 centimeter below the right costal margin on mid-clavicular line. The edge is leafy, firm in consistency, surface is smooth, and moves with respiration. In spleen is 6 centimeter from left costal margin along its axis, long axis. The anterior notch is felt. It is firm in consistency. On percussion, there is no free fluid. Liver span is measured to be 11 centimeter. On auscultation, intestinal peristaltic sounds are heard and there is no bruit. Other systemic examinations are unremarkable.
So when you say the edge is leafy, what do you mean?
It's normal.
So edge is leafy is normal.
Yeah.
So can you feel a leafy edge?
Normal leafy edge will not be felt. It slips between the wall and the finger when you are palpating for the edge of the liver.
So when the liver is significantly enlarged, it is very unlikely that the edge will remain leafy. because this liver has got enlarged due to something. No? Something has got filled into the liver. It's like a infiltration of the liver. So after that, the edge may not remain leafy. So you should use the word leafy for a normal liver only. So if you are by chance seeing a young patient who has a normally palpable soft liver, just palpable liver, there you may talk of a leafy edge. Otherwise, it's unlikely to be leafy.
Yeah, I'll better not comment on that.
Yeah. Okay. What is the
So,
anthropometry?
So, and on anthropometry, the height is 79 centimeters, which is well below the third percentile according to the IAP modified WHO charts. Then the weight is just on the third percentile line, and head circumference is 47 centimeters.
So what does this anthropometry mean, Swapnil?
Failure to thrive change. Height and weight both are reduced.
So there is a little difference in this pattern of affection of anthropometry. So what is that difference? So when is height affected more than the weight? So if it is a chronic illness, will height be more affected than the weight? What is the
Sir, in
pattern
chronic
of
condition-
chronic illness? Yeah,
Sir,
online?
in chronic illness, weight is more affected.
Yeah, go on online.
Sir, in chronic illnesses, weight is also affected more than
Which
the
is
height.
more affected?
So weight is more affected.
Very good. So always remember, in chronic illness, weight and height both will be affected, but weight will be more affected than height. This sentence you must remember, and always, it is always going to be this way, right? So what is the change here? Height is more affected. What does that mean? So when can height be more affected than the weight?
Sir, in endocrine causes.
Okay. So in endocrine causes. So in other words, it would mean that this is a condition which is by itself affecting the long bones or the growth of the long bones. Okay. So it is either endocrine. What are the other possibilities in general where height is more affected than weight?
Skeletal dysplasia.
Very good. So skeletal dysplasias. Okay. So this is that kind of some kind of a condition where height is more affected than the weight. Okay. What will be the weight for height of this child?
Weight is 10 kgs and height is 79 centimeters. Yeah.
So what will be the weight for height for this child? Weight, how much you said? 10 kg.
10 kgs.
Okay. So is height more affected, or means height is more affected than weight?
Yes. Yes.
How? Why do you say that? Means explain that. What is the height age of this child? 79 is
means-
normal at what age?
So after 1 year to 3 months.
Yeah, so 1 year, 3 months.
1 year to 3 months.
And 10 kg is normal for what age?
1 year.
So height is better than weight, no?
Yeah. But as per chart.
Weight is of a 1-year-old child, height is of a 15-month-old child, and the child is 2.25 to 3 years. So height is a shade 3 months better than the weight, no?
Yeah.
If you go by what you just said, height age, weight age, then
Yeah.
height is a shade better than the weight, right?
Yeah.
50th when the weight is 50th centile at that age. So it is coming as 15 months, coming as 14, 15 months.
What? Correct. So what I am trying to explain is that with these figures, you can look at the actual charts. But what I'm trying to say is it is not possible to utter this statement with these figures that height is more affected than the weight. Either you can say in the exam, height is marginally better than the weight. So you can say weightage 1 year, height age 15 months. So height is marginally better than the weight. Or you can say both are 15 months, nearly equal. So height and weight nearly equally affected. We were discussing 5 minutes back, when is height more affected than the weight? That statement cannot be used here. Okay. So if we were to, now that, of course, that 10 kg equivalent to 1 year is a rough approximation. So therefore, if we really see in this child, weight and height both are affected, weight is more affected than height, and therefore it could fit into a chronic disease pattern and not primarily a endocrine problem. Correct?
Yes.
Yeah. So that's about the, now why I asked you what is the weight for height, because weight for height, we are all used to weight for height being low. That's always the case with chronic malnutrition or chronic disease.
Systemic illness.
But one situation where weight for height is high is a endocrine disease where height is more affected. So your numerator, weight upon height, height is more affected, weight is less affected. So numerator is more. So weight for height is on the positive side. This is only one situation in a endocrine disease or equivalent, means skeletal dysplasia or whatever, right? So that's the importance of all these anthropometry. Okay. Now, what are the signs of hepatocyte dysfunction?
Spider nevi.
So again and again, remember that hepatocyte dysfunction and hepatocyte failure are slightly different, right? So when we say failure, we mean end stage dysfunction. Okay. So anything that is away from normal, you start from there. So what are the signs of hepatocyte? And I am asking signs, not symptoms.
Jaundice.
Hold close.
Jaundice.
So better to say icterus,
Icterus.
because sign is icterus.
Yeah. Icterus, ascites.
Before ascites, what should you say? Edema feet.
Edema feet.
Okay, so icterus, edema feet, ascites. Then, so is ascites a sign of portal hypertension or is it a sign of hepatocyte dysfunction?
Portal hypertension.
So that means not a sign of hepatocyte dysfunction.
No, it can be also due to hepatocyte dysfunction.
So tell me the role of both portal hypertension and hepatocyte dysfunction to cause ascites in chronic liver disease. You got my question? How does hepatocyte dysfunction contribute to the formation of ascites? And how does portal hypertension contribute to the formation of ascites?
Hypoalbuminemia.
Sorry, say loudly again.
Low proteins in liver failure, that is by ascites.
So what you should say is that the hepatocyte dysfunction leads to poor synthesis of albumin, which is the starting point because of which you can get extravascular fluid collection. It could be in the form of edema feet or ascites. What does portal hypertension do? It helps to localize that extravascular collection to the abdominal cavity. So that's why you get ascites. So the starting point is hepatocyte dysfunction, and portal hypertension is helping it to localize in the abdominal cavity, right? So this is the contribution of both in chronic liver disease.
Yes.
Okay, fine. And also sign would be growth failure. So you start with growth failure, then icterus, then edema feet, then ascites. Okay.
Yeah.
Now, why? I mean, theoretically, why do you get spider nevi?
So,
What
because
is
of
the physiological derangement behind it?
because of increased portal pressure, there is centrifugal flow is more from the umbilicus.
That is not spider nevi. Now, what are spider nevi? That is the dilated capillaries or dilated blood vessels which you see around the umbilicus.
Yeah.
What is spider nevi?
Small vessels, dilated small vessels on, not around the umbilicus, small dilated patches, kind of small vessels.
Any better answer? What is spider nevi?
So small red marks which we see usually on the chest or the upper back, and they are non-blanching. Like when we press it, we see the direction of the blood flow. So they are blanching. All red vessels dilated.
So there is a central arteriole. See, you have to think of a spider. Now, why did the spider come into the name? So there has to be a central red arteriole with thin lines around it, which looks like a spider thing. That is why it is called a spider nevi. And it can be anywhere on the body. It's not related to only umbilical flow. And it is meant to be due to dilatation of these arterioles, which is meant to be a hormonal disturbance because of estrogen predominance. All this doesn't happen in early childhood. That's why spider nevi is not common in early childhood. Okay. So when we talk of spider nevi, we should know what they are, why they occur, and why they are uncommon in pediatrics, right? Okay. Fine. So now what is your, after examination, what would be your provisional diagnosis?
So I have a 2-year, 10-month-old Virat, male child Virat, who has been presenting with progressive hepatosplenomegaly with mild pallor, with no signs and symptoms of liver cell failure, no signs and symptoms of portal hypertension, probably due to reticuloendothelial cell involvement of the liver, and the probable etiologies I can think of are storage disorders, which is
Yeah. So the most likely differential is a storage disorder.
Yeah.
Okay. Now we had discussed a few more differentials on history. So can it be a vascular component of the liver?
Vascular component, I didn't find any ascites in this child. So vascular.
So in connection with that, on inspection, you said flanks are full. So when are the flanks full?
And fullness is seen in cases of ascites where there is free fluid in the abdomen.
So if you don't have fluid in the abdomen, you should not say flanks are full, because then it is contradictory.
Okay, but so what do I say? Because the abdomen is distended and the flanks are normal, not normal, then generalized distension. Then...
No, so we need to understand this, that what is, So first of all, when we talk of generalized distension, we are talking, what is the concept that we are giving? Generalized as against localized. So localized is for any one organ or a tumor or a mass, correct?
Okay, sir.
Whereas generalized is generalized. So this is one. Now, what does flank fullness mean? So if you were to take a cut section, a transverse section of the abdomen, flank fullness would mean that at both the lateral sides, there is a lot of convexity. That is what you call as flank fullness.
That is not the case.
Okay, so that can only happen with fluid in the abdomen.
Yes.
Otherwise, if you were to take a cut section in the midline, you will have distension. But the lateral sides of that oval cut section, they will not be bulging or convex. So that is absence of flank fullness. And that differentiates organomegaly from fluid. Is this concept clear?
Yes.
Okay. Fine. So because there is no fluid, your Budd-Chiari prototype is ruled out.
So for fluid, I saw, I tested the child for puddle sign. I checked for fluid thrill and I checked for fluid thrill and shifting dullness. None were present. I mean,
so again, like we discuss in milestones, if there is no horseshoe dullness, would you check for fluid thrill?
no.
No. So don't talk of the subsequent sign when the earlier sign is
not
absent. And don't say that I look for puddle sign.
Okay.
Because if you say you look for puddle sign, I'm going to tell you demonstrate puddle sign. Okay. How can you demonstrate puddle
Sir,
sign?
I'll ask the child to be on 4 limbs like a
Animal.
animal, and then around the umbilicus I'll percuss.
Correct.
Yeah.
So it is not easy to do that.
Yeah.
No? First of all, the child has to maintain that position. Then you should be able to percuss ulta. So all that is not easy. So nobody expects you to do a puddle sign in exam.
Okay. So
don't talk of puddle sign. So your earliest sign of free fluid is horseshoe dullness, and you are allowed to miss small amounts of fluid which a USG picks up. That you are allowed to miss clinically. So clinically you will say no fluid. Okay. Fine. So that now can we rule out the other infiltrative disorders besides storage, like a lymphoma or a histiocytosis? Can we rule them out?
Hormonal distension throughout the period. If it's a lymphoma, eventually child will become sick or he will complain of some discomfort in this period.
So that is one reason. Any other reason?
Like a mass is expected rather than a generalized proper hepatosplenomegaly.
So what you would have said is that
in a lymphoma over 10 months, I would have expected other lymph node swellings, if not elsewhere in the body, at least in the abdomen itself. So I would have felt other masses besides the hepatosplenomegaly, which are yet not there. And that is why it's less likely to be a infiltrative disorder like a lymphoma. Okay. How will you investigate this child?
So on investigation, first I will confirm my diagnosis, my finding of hepatosplenomegaly on USG whole abdomen. I'll run a splenoportal Doppler also along with to check if there is.
So it's not a good idea to say I'll confirm my hepatospleno by a USG. That's not a good idea. Hepatospleno is confirmed clinically only.
Okay.
So, but you will ask for a USG for looking for other lymph nodes, etc.
Okay.
But don't say that I will confirm hepatospleno.
Okay. And with USG whole abdomen. We'll look for liver echo texture and signs of portal hypertension on USG. Then I'll run basic workup of complete blood count, liver function test, and liver function test like SGOT and PT.
What is your broad aim of doing liver function tests in this child?
To see if there is any hepatocyte involvement or not.
Excellent.
Yeah.
So you want to reconfirm whether there is subtle or biochemical hepatocyte involvement.
Then since my first differential is a storage disorder, I'd like to go for a liver biopsy.
Examination as well, because organomegaly with considering a storage disorder, so straight away going for the all to see all other skeletal involvement. I'll see if there is any scoliosis and spine and all. And the other thing is I'll do an ophthal exam.
Yeah, so you will do an ophthal examination, that's right. But you can, after that, you can talk about a liver biopsy, which is likely to be a definitive diagnosis. So you should say that I'll confirm that there is no hepatocyte dysfunction. And once that is there, I can safely go ahead with a liver biopsy, right?
Yeah.
Okay. Fine, I think time is also up, so we can stop here. Any questions? Anybody, any questions from the online group?
Sir, I don't understand one thing. When I took the case, I thought that the weightage is actually more affected than height age. The weight is more affected than the height here. But when I plot in the growth chart, I found that the height is actually more.
So why do you say that the height is more affected than the weight? Where is your height? Yeah. So this chart, as we discussed the other day at Hinduja, this chart doesn't tell you the standard deviations. So this chart doesn't tell you how far your current reading is from, or how below your current height reading is from the third centile to quantify the deviation. Where is your weight reading currently? So what is this dot you've drawn?
Sir, age 34 months.
Just now I'm not able to answer you why visually we are getting that impression, but because of the height age weightage way that we discussed, the weight is more affected than the height, because weight age is around 1 year and height age is around 15 months.
Yeah, that I'm also.
Yeah. Okay.
More aligned to think like that only, but then
Sure.
an exam we should give with a growth.
Okay, so thank you everyone for joining in today. And once again, it's a request to please come for physical classes. Even Nilu ma'am's class is going to be physical, and she's going to get a child and she's going to demonstrate a lot of science. So it will be very good learning if you all can come physically. And because of your requests, we have requested her to take it a little later in the evening. So it's going to be 5 to 7. So please come in. Thank you very much.